right, can everyone please have a seat? All right, today it's my pleasure to introduce Dr. Amy Godecker. She received her bachelor's in psychiatry from the University of Chicago and proceeded to receive her master's and then PhD in sociology. Her theses were on gender role, attitudes, and marital quality in female and male sterilization, and wives and husbands' perception of marital quality and dissolution. So if anyone has research interests in that area, let her know. But that's not the subject of your talk today. She has worked on the UW Life Course Initiative for Healthy Families, and prior to that worked on several projects with the Carbone Cancer Center. Currently she does research with our department and also public health, epidemiology, and quantitative social research. And her talk today is actually on a slightly different topic. It's just sort of on general hands-on research resources for residents. And I know that the residents are, some of them are interviewing, but this will be available on YouTube. And so prepare for viral stardom. So without further ado, Dr. Amy Godecker.
So, as Dr. Anthony said, this is a little different talk. It's not on a particular research subject, but trying to talk about research resources, and hopefully the faculty here will learn something as well, but it really is going to span from very basic to a little more information, so hopefully everybody will get something out of it. So first I'm going to start with my background and my role in the department, since this is a new position for the department and there's still a little bit of confusion, I think, about who I am and what I can do here. But then I'm going to move into touching on several parts of the research process, such as study design and surveys and data management and analysis. And for each of these sections, I'm going to talk a little bit about the topic itself and then how I can help you in your role as a researcher, and then some other campus resources that are available to you and how I can help connect you to them. So for learning objectives, at the end of the talk, you'll know who I am and where to find me and what I can help you with. You'll be able to identify several key resources on campus and give examples of study components that you'll need to prep for before you talk to your biostatistician. And I don't have any relevant financial disclosures to report. So, who am I? A little bit about my background, and with a nod to the talking heads, well, how did I get here? I was born in Kentucky and grew up there, but then went to college at the University of Chicago with a degree in psychology. Didn't know what I wanted to do with that, so I moved to DC after that and worked for 3 years for a contractor that did contract research for Department of Education and Department of Health and Human Services, and did a lot of survey work and other kinds of research there. Realized after a few years, everybody above me has a PhD, I guess I better get one of those. So I applied and ended up at Madison here, in part because of the lovely lakes and the quality of the sociology department. I spent my time here in sociology. I was a NIH pre-doctoral trainee with the Center for Demography and Ecology. And in addition to my focus on demography, which I did a lot of work on family and fertility, I did a lot of coursework in gender. I took a couple nursing classes in women's health and history of medicine, focused on women's health. So when I finished, I realized I didn't want to teach, I didn't want to go the professor route, I wanted to continue to do research in women's health, and took a job at UCSF with the Bixby Center for Global Reproductive Health. I worked there and at the UCSF School of Nursing's Institute for Health and Aging for a few years, where I was a contractor for the California Department of Public Health, working on issues of family planning and maternal and child health as an epidemiologist and an evaluator. And then went to Minnesota. I was in the Twin Cities for 4 years, where I worked for the university there on health insurance coverage issues, and then for quite a while with the Minneapolis Health Department as an epidemiologist and evaluator for their Twin Cities Healthy Start program, which focuses on reducing infant mortality for low-income women. So when I moved back here, after about 10 years away, I got a job with Carbone and was managing the survey research shared resources, it was called then, and I'll talk a little bit about that later as a resource that many of you can access. I liked it a lot. I was doing research, but I really wanted to get back into maternal and child health. So when Dr. Ehrenthal came here and took over the Life Course Initiative, I was really happy to join her team as the evaluator for the Life Course Initiative, and worked on that for 4 years, and that wrapped up. Actually, we just submitted our final report a few weeks ago. Thank you, God. So I'm really here now. But it was a great experience working locally and working on these issues in Wisconsin. So how much I published kind of depended on what kind of job I was in, whether I was doing more information for policymakers or things that were publishable. So I published in a variety of family planning and contraception and maternal and child health journals and presented widely on those. So wide variety of topics. I'm kind of more of a generalist than deep into any one specific thing. I've done the most work on health equity and health disparities in infant mortality, but I've also worked on maternal mortality and contraception and a whole lot of other things. So I'm learning a lot while I'm here, but I bring with it kind of a population health perspective on a lot of the issues that you all are working on. I've used a lot of different types of data sources, national data, a lot of statewide data, anything from vital statistics to hospital discharge data to statewide surveys. I've worked on projects with chart abstraction, qualitative research, focus groups interviews, structured screening interviews, program utilization data. So I have a wide variety of experience working with different kinds of data. You'll notice here that clinical data and clinical projects are underrepresented. So I'm bringing my population health experience and learning is from you all, but a lot of the methods and types of data collection that I've done over my career are applicable here. So developing that, but I think I bring a lot to it. So where I'm situated in the department is with the Clinical Research Office, led by Jenny Petter, who's the Clinical Research Administrator, and we work closely with Dr. Kushner, who's the Vice Chair of Clinical Research. There's research coordinators and a finance coordinator and program manager and a regulatory specialist in that office that can help you with study administration, regulatory support, some financial accounting, pre and post award, but also billing for your studies and such. Study coordination and subject recruitment for clinical research. My role is a little different because I am not only working on clinical research, I'm a resource for the whole department. So I'm a little bit unique in the clinical research office that I'm working more broadly with the department, but I can help you with things like study design, data acquisition, data management, analysis, from all levels, from residents, fellows, faculty, and so on. I'm also the primary liaison for the department between ICTR Biostats and Carbone Biostatistics Shared Resource, and I'll talk a little bit more about that resource and relationship later. I can also help you navigate to other campus resources, such as the UW Survey Center, and I'll talk about them as well later. So let's switch gears and talk about one of the early components of study design. One of the things I've gotten the most questions about since I've started is sample size calculations. One of the kind of basic things when you're designing your study, how to get going with that. So there are 4 pieces of information you need at a minimum to be able to look at your study design and determine how many people you might need to recruit for your study. So first, you need to know your significance level. This is your alpha, the probability of rejecting your null hypothesis or saying that the null hypothesis isn't true. It isn't true when it is in fact true. By convention, we use 0.05 for a lot of our studies. Other disciplines and other types of studies, even within our discipline, use a higher p-value of 0.01 or something like that. But that's one of the variables that you need to decide. The second crucial one is power, which is 1 minus beta, where beta is the probability of failing to reject the null hypothesis when it's false. So deciding that you don't have a finding when in fact you really did have a difference. You're looking at an intervention and deciding that my intervention didn't work when in fact it was a real difference, but you couldn't detect it because you didn't have enough power to detect it, or it was just random that you didn't. And a lot of times for this, we tend to use 0.8, but I think that's pretty conservative in a lot of ways. It makes your sample size lower that you need for a power of 0.8, but it means that if you were in your study 100 times, 20 times of that, just by chance, you would reject your idea even though it was really true. So that's one of the things you need to think about is the kind of study you're doing and what level you want to power it at. So you also need estimated values for your comparison group, your control group, and estimated value for the intervention group. So what is your effect size that you're trying to detect? The expected difference between the groups. And this part is really difficult sometimes to get, the standard deviation for all those values. So that, you know, something about the variance, a bigger variance in your estimates means that you need more people to be able to detect the same difference or same effect size. So before you would do the power or sample size estimation yourself, or before you would talk to your analyst about it, you need to do a pretty deep literature review. You need to look at the estimated mean for your control group, think a lot about your effect size. If I do this intervention, if I give them this drug instead of that drug, what change do I expect to see between the two groups? And think really carefully about what is clinically meaningful. If you could detect a really small difference but wouldn't change your practice based on that, you don't really need to detect one that small. Think about at what critical point you would change your clinical behavior or decide to go this route instead of this route. And also think if you're talking in terms of a proportion change, say I expect a 30% drop in X based on giving them this treatment instead of that treatment. Are you talking about a relative change or an absolute change? And those sorts of things the analyst is going to ask you about when working on your effect size. And you also need to think about your standard deviation, which can be really hard to come up with because a lot of literature that publishes power calculations doesn't publish the standard deviation, even though it's critical. So you also need some information to get the number of people that you'll approach and figure out the length of your data collection and your budget. You'll need to think about how many people are eligible during a given time period. If you're thinking your study's going to run a year, how many people in a year do you see that meet those inclusion or exclusion criteria? Or how many people have a certain condition or whatever. So this will affect your allocation ratio. If you're doing a case control study, looking at something that's a little more rare event, you're likely to have an allocation ratio, which means the number of controls that you have for each case that you have will be bigger. You might need 3 controls for every case. So that would be an allocation ratio of 3. And you need to think about your expected consent rate. What are the no-shows in your clinic? If you approach X number of people, how many people do you think will enroll, and so on. So people generally don't do power calculations by hand. There are lots of calculators out there. I use the one in Stata and like that one quite a bit. So I'm going to show you a little bit about what it can do, but other types of things will do this as well. And these are the sorts of things that you can go through with your analyst and talk about it. So we've got total sample size. This will also give you, so this is just a simple example of a comparison of means, that the mean for a value for your control group is similar to your intervention group would be your null hypothesis. This is the same as for proportions. There are other more complex designs like correlations that you would expect to change and so on, but I'm going to stick with the most basic example. So you have to enter your significance level. You can enter different powers, so you can play around with it and see, if I change the power, how does that change my sample size? Or if you know you have a given number of people, you can enter that, and then it will tell you what your power is. So all these numbers play off each other, and you can estimate any one of them. So for this, I just said, let's say it's a mean of 140, but I'm not sure what difference I want to be able to detect. Let's look at 3 different differences, a difference of 5, 10, or 15. And I'm a little wonky on the standard deviation. I'm going to look at 3 different standard deviations as well. So it'll produce a table for you that gives all possible combinations. Any one of these is valid. You need to look carefully at it and think about your project and what your goals are and what your research shows that might be a possibility, because this gives you a low of 10 and a high of over 1,000 people, and the full range in between there. And you need to think about the inputs into this and your study to decide which of these you think is your best way to go. It'll also give you some nice graphs that you can illustrate this with. So this is a more simplified version with just alpha of 0.5, a difference of 10 between the groups, and looking at 2 standard deviations, 30, 13, and 25, and calculating across a variety of powers. And you can see that you might not want to go with the bare minimum. If you're able to, the power of 0.8, you would need 56 people total. But for 0.9, you'd only need 18 more. If this is a quick study and it's cheap to enroll, and there are enough people, why not power your study higher? And for some things like a drug study or other sorts of intervention, you might even want to power it even higher. And if you're unsure about something like the standard deviation, give yourself some wiggle room so that if the numbers that come out in real life are different from the estimates that you had to pull from who knows what literature, that you don't end up with a study that's underpowered to actually find a real difference. So I can help you with the study design, talk about the different options in the literature, and help you think about what inputs to go in there, and the range of different options. For more complex study designs, I'm likely to recommend that you go to Biostats, because I'm not quite there yet. Some more complicated methods. So let's switch and talk about a different part of the study process, study design and data collection. So one thing that a lot of faculty and residents are doing are surveys. Sometimes they're big, sometimes they're more ambitious, or sometimes they're small and sometimes they're a little bigger, but they all need the same careful thought to go into them. And I think a lot of times people think, oh, you just write some questions and ask people, but there's really a lot of science that can and should go into a survey. There's a lot of survey methodology research out there. It's a whole discipline. I know a fair amount about it, but the UW Survey Center knows a lot about it. So I'm just going to feature one thing that might be of substantive interest to you, but is also an example of a kind of research that survey methodologists do to look at different question ordering or ways of asking questions that can really affect the results that you get from your survey. So one that was published a couple of years ago by some of the leaders at the UW Survey Center was looking at response order options on self-rated health. So self-rated health is this kind of global question that says, would you say in general your health is? And the options range from poor to excellent or excellent to poor. And it seems like such a simple question, but there's a huge literature behind this question that shows it is a really good way to, simple question to capture a person's perception of their own health, you'd have to ask a whole battery of other questions to be able to roll it up into this one thing. So it gets used a lot as both an independent and a dependent variable. So knowing some more about it is kind of important. So what they did was look at a 2x2 factorial experiment. They looked at the ordering of responses. If we say poor to excellent versus excellent to poor, what difference does that make? But also looking at, should we ask this question before we ask other health questions, or should we ask it after? So they randomized people in their survey to these 4 cells and ended up, from their results, recommending that you start with poor and work toward excellent in your ordering, and ask the self-rated health question before other health questions, so you're not kind of priming them by the particular kinds of health questions you're asking about. So that's just one example of, you might not give much thought to a simple question like that, but there's a lot of research behind it to show how to do it well. So in general, some other good survey practices, your results are only as good as your sampling frame. If you're interested in something about Ob-Gyn County, only having recruit subjects from Meriter is not going to get you to be able to generalize to the population that you want to be talking about. And that's, again, a simple example, and there are lots of different varieties of it, but it's really key to tailor who your subjects are to the population that you want to be able to speak to. Response rate matters. We're often, with clinical research, are focused on the number of people, and I just went through this whole thing on sample size calculations, but for surveys, response rates matter a lot. Sometimes journals won't publish if it's not a certain threshold, sometimes 70% even, which is hard to obtain. You need to really think about how to do everything you can to boost that response rate so that you're not getting just kind of a convenient sample of, well, I got 3% of people responding, and you're saying that they're representative of the people that you wanted to study, but you really don't know much about them if you don't know anything about the people who did not respond. So one thing that you can do to beef that up is to have a very good follow-up plan to increase your response rate. Phone calls and repeated mailings and that sort of stuff is really important. You can't just have a one and done. There's also a lot of literature that shows that cash is really what drives incentives, and really a pre-incentive rather than a post-incentive. It seems a little counterintuitive to mail cash to everybody and say, but not everybody's going to reply. I'm just wasting money on the people that don't reply. Why don't you pay them at the end? But you get more bang for your buck and you increase your response rate, and it really is cost effective to do any incentives ahead of time instead of after the fact. And cash works a lot better than either gift cards or a raffle or any of those sorts of things. And it doesn't always have to be a lot of cash. Even $2 or $5 can make a big impact in your response rate. But there's also kind of a sub-literature of populations. There's clinicians might have to have a different sort of incentive than your patients and so on. So use validated items and scales when you can. I've already come across several instances where somebody said, I want to do a survey on this and nobody's ever done it before and I'm going to do it. And this particular one, there was actually a whole industry on these sorts of surveys that people have done a lot of research and a lot of validation of items about the thing that they were wanting to study. They were right that that population that they were interested in hadn't been studied before, but they didn't have to start from scratch. They could work with other materials that were already available and already validated. Their agree-disagree items are still widely used, but there's some literature that suggests that they shouldn't be quite as much, and I would urge you to think about not using them. That would be a question like, so there's one from the General Social Survey that's part of a scale designed to measure political efficacy that says, the average citizen has considerable influence on politics. Do you strongly agree, agree, neither agree nor disagree, disagree, or strongly disagree? So the recommendations, and this again comes out of a paper from Jen Dykema and her colleagues at the UW Survey Center that kind of summarized a bunch of this literature, is that you use a construct-specific format instead. And an example of turning that around so that you're focusing on the construct you're trying to get at more than this kind of vague general statement of agree, disagree, would be to say, how much influence does the average citizen have on politics? None, a little, some, quite a bit, or a great deal. And that direct method of questioning in this construct-specific format is argued to yield more reliable and valid data because it's easier for the respondent to process. The burden cognitively is not as great, and it's also less likely to be misinterpreted or associated with other response effects. So that's just one example of how you could turn one of those items around. That's also an example of a bipolar item. It went from, disagree, strongly disagree, to strongly agree. So you've got both directions on there and neutral in the middle. And instead of doing that, methodologists recommend, for the most part, using unipolar items, only going one direction, saying, do you agree with this? None, a little, a lot, a great deal. So unipolar instead of bipolar is easier for a respondent to answer. So pre-test your survey can be really important in figuring out some of the problems with it. Okay. So I can help with a lot of this. I have experience writing surveys. I have experience commenting on surveys, fielding surveys, talking about different ways of collecting data, whether it be telephone or web or mail, use of incentives, what kind of sampling frame, reviewing drafts of surveys or your approach letters. I have experience with Qualtrics in REDCap, and I can analyze the survey if it's not too extensive. But we also are fortunate to have the UW Survey Center on campus. They cost money, I understand that, but they really are good value for all they can give you, given their expertise and experience. And I can guarantee you that they're a lot cheaper than most survey centers out there. They can do everything from your study design and helping write your instrument, translating it into a Spanish language, all the way through administering your survey and doing some of the analysis. So a lot of people don't know that you can get a 1 hour free consultation with them, and in that 1 hour you can get a lot of information that's really useful. I've taken surveys to them that I thought were a pretty good draft, but I still got some really good information on things that I should change and how to word things differently, or if I was more concerned about the incentive, we could discuss that. If you want them to do more, they'll give you a detailed budget estimate. So sometimes you get the most, if you have a limited budget, you're going to get the most bang for your buck probably by asking them to review your survey and give you detailed feedback on it and do some rewriting. And maybe also do your survey layout. The layout of how it looks either on the web or on paper can be really important for boosting your response rate. And it's really not that expensive to have them do those components. This is just a ballpark for not too complex a survey, but they can review one for maybe about $1,500 or do the layout for about $2,500. So that is how some of the residents have used their $5,000 budget is putting the money into getting their expertise on writing and laying out the survey, and then doing some of the administration yourself. It's really difficult for our department to do cash incentives. They do it all the time. It's routine for them. So sometimes you might want to pay extra if you really think a cash incentive is important. You might pay extra for them to at least put the envelopes together for you, because they can attach the $5 bill or whatever it is and send it out. Where you getting the money and doing that is administratively a real hassle. So they also have a lot of experience with follow-up. They have a whole phone bank to do all that, and they have years of experience. And I've done a lot of research specific to clinicians, patients, women's health, and so on. So there's another survey resource on campus, though, that you all can draw on, particularly if you are a cancer center member, or your mentor is. When I was director, it was the Survey Research Shared Resource, but now it's called the Cancer Prevention and Outcomes Data, or CPOD, Shared Resource. And Amy Trentham Dietz in Pop Health is the faculty director of that. And they can do a lot of different things, including data collection, surveys, but also focus groups and so on. They can do qualitative and quantitative. They've done specimen collection. I worked on a project where after we got the subject's permission, we got mammogram reports, urine, a buccal sample. So they can do a variety of things, though they would tend to work on often smaller projects or pilot projects. If it's bigger, they're also going to reuse the survey center. But the thing that they've developed in the last few years since I left is being able to work more in-house with cancer-specific data. They have access to the UW Cancer Registry for a number of years, and also work closely with the State Cancer Registry. So they can do some of the analysis for you that might be toward the beginning of a grant application or for your background part of a grant application or a publication. What does cancer look like in Wisconsin around this particular thing or this utilization? They can give you some of those numbers. They also have access to the UW Enterprise Data Warehouse, which is also available through ICTR. I think a lot of people don't know about this, but it pulls from health record data to look at, to have it a little more centralized and researcher friendly, but you still get them to do the query for you. And it's really good, a feasibility resource. So from 2004 to 2012, how many patients did we have at UW who met this disease condition and had this procedure? It can be critical for knowing whether or not you have enough patients to be able to do the study that you're interested in, or whether you're going to spend a lot of time trying to recruit people but never have enough of them. They also have access to SEER Medicare and SEER-STAT, and work closely with WISOR, the Wisconsin Surgical Outcomes Research Group, on SEER Medicare. So that's emerging data from Medicare claims from the time a person is eligible through their death, if they had cancer at any point in there, with cancer registry data. It's not national, but it's available for a lot of different locations. And Wisconsin is now participating, but hasn't actually given their data yet. So not necessarily Wisconsin specific, but it's used a lot in studies of national cancer sorts of things. They also have access to the SHOW cancer survivorship module. So let's just talk quickly about data management, which I know is boring, but it can be really critical for the timeliness of your project and the validity and quality of your data. And you need to have this done before it goes to your biostatistician. A lot of times, I think people think you just enter all your data and it goes over to biostats. But they are too expensive and don't want to deal with recoding variables and those sorts of things, you need to do a lot of that work in-house before it goes off to your analyst. And it's also really important to get this right for replication of your study, so that somebody in the future can replicate it, or you yourself, when you get your revise and resubmit 6 months after you submitted an article and go back to it and go, like, oh my gosh, how did I code that variable? You need to document all of this stuff. So in the interest of time, I'm going to just zip through some of this stuff. But it's things like coding with numbers instead of letters and words, making your variable names machine readable and consistent, labeling everything really well, documenting everything and being really consistent. Work closely with your analyst on some of this stuff, especially how you're coding stuff, but as I said, most of it will need to be done before it goes to them. De-identify as much as possible and document what you do. So here's a quick example. I randomly generated the MRNs, but the rest of the variable names come from a project I've been working on. And you can see that you couldn't just import this spreadsheet into a stats package, because there's all this sort of stuff at the top. It won't deal with spaces and all that stuff. So you need to fix that before it would go to your analyst in a format more like this. So there's other sorts of problems you would need to fix, like data entry errors. Your MRNs aren't going to read right because you've got a character in there. Inconsistencies in how this was coded and using words instead of numbers. You've got to fix missing data. That's an out of range data point that your analyst is going to know what to do with. You're going to have to decide what to do with it. This is text in a numeric field, but it's also another form of missing data. This one here is missing, but they had a visit. This one is, they didn't have a visit at all, and you know even less about them. You might want to code them differently. And then here you've had two people doing data entry, and they've done it differently. And you need to clean that up before an analyst is going to be able to work with it. So I'm going to skip this, except to say recoding variables can also be really important, and that's something that is, it seems routine, but you need to think about in terms of what your project is and how you're going to use this variable or analyze it. This is PHQ-9. You have to figure out how to attach the numbers to the little check boxes that you gave your subjects. You need to figure out what to do with missing values. People skip stuff all the time. What is the procedure, the standard for the PHQ-9 on how many missing values you can accept, how do you code them, what do you do with those people? And then you need to decide how you're going to treat it. Are you going to treat it as a continuous score here? Are you going to categorize it into these 5 categories? Or are you going to categorize it into these 3 categories that are the ones that are actionable? All those are decisions that you need to think about before somebody starts the analysis. Or it's not going to align necessarily with your research ideas and how you want to proceed with it. So I can help with a lot of this kind of stuff, talking through the beginning, how to set up your database properly so that you save time at the beginning and not have to do as much cleaning at the end. Talk about how to score a module or tool, what to do with missing data, linking data, help you find somebody else on campus who can do something like geocoding your data. Just the frustration of you writing your data and why isn't this working? I can help look at it and sit through and figure out what the problem is, and check the data format to see if it's really in a good spot to go to Biostats, because in the past they've gotten a little ticked off at how dirty some of the data is when they got it. So let's talk about Biostats. Since we're getting short on time, I can discuss your methods and analysis plan. I can help troubleshoot problems. I can do some of the analysis, particularly if it's an unfunded project and small scope. I can also help you find somebody to do the analysis. Oftentimes that'll be the Biostats department, and we have a couple different ways into the Biostats department. Everybody kind of talks about if they're Biostats, but they're not a separate entity. They are a kind of on paper part of the Biostats and Medical Informatics department. We have two different portals that we will commonly use to get into, access those services. So ICTRS is, what was it called? Biostatistics and Epidemiology Research Design, or BIRD, and Carbone Cancer Centers is the Biostatistics Shared Resource, or BSR. So what will I do for you? So those two resources are available for unfunded projects or projects that are funded internally with UW funding. They'll work on projects at no cost to the PI, but only if it's a small scope project, which they define as less than 5% FTE for their biostatistician. So if you have external funding, they expect you to build in funding for the biostats support into your grant budget. And you need to discuss this with them well before your grant is submitted to make sure that they think you have enough time allocated and budget allocated for the stats that you expect them to do. And also the work, prior to that, as you're doing your power and sample size, that can help with all that. And designing your database and that sort of thing. So expectations on their end and ours, we're working on collaboratively with them to develop some of this. You're collaborating with a scientific peer. This is a shared resource, but you're not hiring a mouse imaging machine. This is their expertise and knowledge that you're supporting their salary with. So seek help early with them, preferably early in the study design. But before you give them data, you need to have your IRB approval or exemption in place. You need to give them sufficient lead time. They need to get to know your data and run the analysis and give you results and get feedback and maybe rerun it. And that takes time. You can't have a grant due in a week and say, I need this right now, because they have a whole queue of people ahead of you that they prioritize grant applications and they prioritize cancer projects and some other things, and they might not get to yours in time if you don't give them enough time. They also expect co-authorship. Like I said, this is a collaboration with a scientific peer. We're still negotiating with them under what conditions merits authorship, how much of a contribution to a project, and so on, and we'll release more information about that later. But just know going in that there should be a discussion at the very beginning about authorship. So to request a consult, you can go to their, so on the ICTR website, this would be here, free consult request. You go in and biostatistics and research design, but also note all of these other resources that the ICTR can help you with. Both website portals will feed you into the same form. It looks different on the page here, but it's the identical form. It'll ask questions about which project it is, who the PI is, how's it funded, is it cancer related, do you already have a biostatistician in mind, and all sorts of things like that. And then it funnels into one person who does a triage and says, this is something we can do, this is something we need to have more discussion about, this is something that can be funded through ICTR or Carbone, and we'll assign a researcher and get somebody working with you. And usually that process does go pretty fast. So we're lucky here. We have an embarrassment of resources at the UW. The UW lately has been trying to centralize some of the information about these resources. I am still learning about them. I've worked with a fair number though, and am happy to do some of the legwork and tracking down some of what's available for what you might need for your project. So I'm going to stop there except to say that a lot of grants require an evaluation. I have a lot of experience with evaluation, and if you need an evaluation plan, I can help you determine that, to meet the requirements of your grant. But I did also work for a number of years with the Population Health Institute, which is a team of over 30 professional evaluators who can be contracted with to do the evaluation. And there are some projects with our department I know who are doing that, and for 5% of OPI's time plus some RA time, you can get the evaluation component of your grant requirement taken care of without you having to hire and do the work yourself. So how can you reach me? I'm at 4th floor McConnell. Best way probably is my email, which is godecker@wisc.edu, but I'm happy to come to you. I know you guys are all busy and in clinic and out of clinic and all these other things. So whether you're at Wharf or one of the hospitals, whatever, I can come to you. So that's it, I think. So I don't know if people have questions. No. Yes, Michaela.
Amy, you mentioned that you're able to work on small scope projects. How do you define that?
Well, it's kind of ad hoc. It depends on what else I'm working on at the time, and what you're asking. Like if it's an analysis, what is the timing of that in relation to what else I'd be working on? So far, like I've done things that had, a case control study with 300 people, a survey with a couple hundred people. I am working on a project with Dr. Brown that's using NHANES data, so it's a lot more people, but it's population health data that is fairly familiar to me, so it's easier to work with. So it's really kind of on a case-by-case basis. So we can talk some more if you had something specific in mind. A lot of them end up being resident projects that are unfunded and fairly simple analyses. If it's more complex, it might need to go to Biostats just for time reasons, but also to make sure that you have your Biostats in order for the study design. Dr. Krishnan?
Can you comment on your roles in terms of resident research program and their education, and how do you see that?
Yeah, so I am working with the clinical research office and also the resident program managers and education specialists to increase the component of the resident education that addresses biostatistics and research methods. So the expectation is that you do a research project, but in the past they haven't gotten a lot of training in that necessarily. It's been more one-on-one or on their own. So beefing up a little bit more the part of the Thursday University that addresses that. Also doing a lot more one-on-one consultation around it and working really closely with Drs. Anthony and Cooney, who are the resident research mentors, to help support them in addressing needs or issues that arise.
Great presentation. Thank you for catching everybody up. I think what you're doing is going to be really helpful as people proceed. I'm kind of curious, so now that you've been in this position for a while, where do you see your intersection with the population health research group?
Yeah, that is a great question because it is, as you know, that is where I come from and it's dear to my heart. So I'm getting up to speed on some of the clinical ends of things, working some more on the resident education component, but I think as that settles down, I do hope to engage a little more in that. I am also conscious of when somebody comes to me with a clinical question, thinking about, is this really something that you should answer with clinical data? There's a lot of population data out there that you should be interacting with. And I would like to develop some more resources for the department so that people know a little bit more about what's out there. So that if you have a question that's really about kind of prevalence of something, why are you going to do something local? There's national data out there that already answers that, and is you don't have to do all the legwork on, it's already available, and it's more likely to be published. So engaging with the people in your division in terms of what they're working on, but also kind of trying to broaden the experience of the department in terms of population research and getting people more engaged. Anything else? Yes?
I apologize if I missed it, but I think the residents are used to be having a quality improvement project requirement, and there's a lot of faculty that are interested in quality improvement as well. What's your thought about quality improvement work and your role essentially in that?
I have a little bit of experience with it, not in clinic, but more from a little bit outside that, in terms of public health programs and such. But I think that I understand enough of it that, and a lot of the methods are very similar in the data collection process and so on. So I think I can help support that as well. And a lot of the resident projects already are QI, and I've been working with them on those. So sometimes there's a fine line between the research and the QI, and I think working with our regulatory specialists to determine that and to make sure that we're doing it well is important, and I'm happy to support that. Jenny?
Hey, Sammy, it was Karen Garden. I know sometimes in my interactions, sort of norms of social science are so different from norms
Yeah.
of clinical medicine. So could you talk about, like, if you could wave your magic wand, how much lead time would people maybe give you if they want a consultation on a project? Do you know what I think? There's often so little time, so much rush in clinical medicine that, just tell us a little bit about how you like to work.
Well, ideally, so far it's been kind of seat of the pants, but ideally, before a consultation, I get the proposal or the draft manuscript or wherever the project is in that stage, so I can do a little prep ahead of time. Sometimes I've been pulled in to kind of on the fly give an opinion, and I can do that, but it might not be as deeply informed as if I had more lead time. So, a few days, a week even. For some projects, if it's going to be bigger, like doing the analysis, getting a heads up on that when you're developing the project, so I can give input into that and kind of mentally put it into my queue and figure out how to balance my time that way would be great. So there are projects I've committed to that are still probably 6 months away from completing data collection, but I already have been involved a bit in it and prepped on it so that when the data come, I'm ready to go. Okay, I think that's it. Thank you.